Thank you so much, Craig, and thank you to everybody for inviting me to be part of this local conversation, which is really exciting. I'm old enough to have visited the JBI offices in the very original form as Helen Pearson back in the old Royal Adelaide offices. So it's amazing to see how far JBI has grown and developed since then. So it's congratulations, it's really fantastic. But also I really love the idea of the local symbol. In Sydney Nursing School, localism is our core philosophy, and we've done quite a lot of work to look at how do we position ourselves as a local school, and it's a really important concept, I think, for all of us to think about, particularly given the current context that we're all working in. But before I go any further, I too would like to pay my respects to the traditional owners of the lands that we're gathered here today, and to pay my respects to the elders past and present, but also to acknowledge the thousands of years of this kind of knowledge generation that's been happening and the shoulders of the giants that we stand on, which is always a humbling moment, I think, no matter what it is that I'm doing, to kind of just keep that in my head is a really important thing for me. But it's really good to be here and to kind of kick off this conversation. There is so much I would want to say, and I've only got 35 minutes or so to say it. So it's a little bit of a rapid journey through a lifetime of work, really, and a whole global movement that's happening around the world at the moment. Some really exciting stuff happening, but also some real challenges as we go through. So I've decided to kind of pitch this into three parts, really. One is why it is we do this, what's the reason for it. I could spend the whole day talking about my own personal story in this space, which goes back quite a few years, and why I still feel as passionate today as I did back in 1980 around why this work is so important and why we can never let go of that work or take it for granted. The issues have not changed in my view, and I don't think they ever will. It's the nature of being human, and therefore we have to keep with it. So I want to talk a little bit about some of those challenges that we are currently experiencing, and then talk about the person-centered practice framework in particular, and the work we're doing in that space and how we use it to change culture. It's not blatant self-promotion. It's just a framework that has given me a living for the last 30 years. So I carry on working with it, and still seems to have traction. And as long as it does, then I'll carry on spouting forth about its importance. So I think to state the obvious, it's fairly true we all work in complex organizations. And when we work in complex organizations, there are no such thing as simple solutions. That embracing complexity is at the heart of what we do. And I'm really interested currently in some of the work that's happening around complexity science and how we bring that thinking into healthcare more formally. Some work that we're doing as a school with the Broken Hill University Department of Rural Health, where we're kind of using complexity science to look at remote health as a form of global health, because actually the issues are the same when you look at remote parts of Australia to what's happening in global health context, particularly in the global south. So that idea of how we embrace complexity, I think, is a fundamental starting point for all of us. Too much of the work that I do is people looking for quick fix solutions, looking for that simple thing that's going to fix problems that have been around for many years. And it's not to say that everything has to be so complex and so just intricate that we can't get our finger on it, but equally we have to recognize that quick fix solutions take us nowhere. They just are plasters that we fix over huge problems, and we need to stop that kind of mentality. And again, I could talk for a long time about how I see the QI movement not doing us any favors in that regard, because if we can't fix it with a PDSA cycle, then how do we fix it? And I've used a conference presentation before to argue, how many PDSA cycles do we need to change a culture? Because actually I just see people going around these cycles and yet no significant change. So some of those things I think we need to start being challenging about. But when we strip away the whole person-centered language and the complexity of the argument about terms and whose words are more important than others, fundamentally what we are trying to do is to enable people to flourish as human beings. Human flourishing has a very long tradition going back to Aristotle, and Aristotle described it as our fundamental reason for being happy, that being happy is our core reason for living. And it doesn't mean happy as in haha, but happy as in just living a good life. How do we actually live a good and worthwhile life? And for Aristotle, that means that we are, which is a good evidence-based practice connection, that is doing the right thing and doing the thing right, and connecting our mental and emotional abilities with our ethical stance in life, and that we have to bring all of those things together if we are going to live a full and meaningful life. But for me, human flourishing is the absolute core of what it is that I'm passionate about in relation to person-centeredness. How do we help patients and service users and consumers to actually really get the best from the system that they have to connect with? How do we enable our staff to ensure that they are doing their best at their work, and that we provide conditions that enables them to do their best and to really flourish as persons? And we know that there are many staff, to use an Aristotelian term, who are languishing. And languishing is at this horrible state that Aristotle describes as a state worse than death. Now, it's not necessarily as bad as that, but if we are stuck in a job and we don't want to be there and the conditions aren't great and we just don't feel good about ourselves, then how the hell do we expect those same nurses and others to provide person-centered care? It just doesn't work. And I remember that lesson coming clear to me really early some years ago, and I was watching a program on the BBC London, and they were talking about homelessness and care workers, and they interviewed the single mother who is an assistant in nursing in one of the nursing homes in London, who basically, didn't eat most days, and she had been sacked for stealing food from the nursing home. She lived in a hostel with her young son, and yet she was working in one of the top care home providers in the UK, who have all over their philosophy about person-centeredness. Now, the irony of that for me was just too much, because I just think, you absolute what's-its, that you think it's okay to kind of sell this idea of person-centered care, but yet it's also okay to sack someone just for taking food because they can't eat. So this whole idea that somehow we treat different groups of persons differently is a core issue for me in terms of how we do person-centeredness. And hence, human flourishing, there's no hierarchy of flourishing. We all have a right to flourish. We have as much right to flourish as patients do, etc., etc., etc. So that's the core thing. However, we know from our current health systems around the world, and the latest State of the World Nursing Report has just been produced, which doesn't tell a happy story either, and things haven't changed that much in the last 2-3 years since the last one. And a couple of years ago, I wrote a paper which posed this question of, do we actually have a shortage of nurses around the world, or do we have a global shortage of workplaces where registered nurses want to work? And for me, it's the latter. I don't know that many nurses, other than those who have chosen to retire, or whatever word you want to use around that, or do something else, who actually don't want to work, who don't want to do their job. But I know many nurses who don't want to work in particular places, and I'm sure you do too, which is one of the reasons why we're here today. And there's plenty of data to show us that that is an issue, that when nurses are asked what is their top priority in terms of their work, number one is a safe environment. It's not salary. Salary is down the list here, even though, of course, that's important. But the thing that nurses strive for most is a safe environment. And we're not talking about necessarily the technical patient safety kind of thing, even though that's also important. It's that psychologically safe environment, a place where people can flourish, to do their best work, to be the kind of people that they want to be, and to provide the kind of care that they want to be. And yet we know that there are still many, many, many environments here in this city and in every other city around the world where that is not happening, where people are really struggling, and therefore they're not flourishing in their work. But it's also not just a nursing issue. We see it happening around the world too in relation to medicine. So junior doctors have been really fighting this case too. And whilst it's been locked into a kind of a more pay kind of argument, when you read the narrative around the junior doctor fight, it's really around conditions, really around their ability to do their work, and how pay kind of is a representation of that as something that they can hang on to. But we also see it with paramedics, and we see it with allied health professions. So it's not a nursing unique issue, but it is a context issue. It's a culture and context issue in relation to our health environments. And the more recent one, that kind of really troubles me is around the whole digital and AI developments. And this is an editorial that came out last week that I wrote around the whole problem, as I see it, in relation to digitalization and AI in particular. The zeal that we have in place around developing digital models, and yet we have very little evidence to demonstrate that they make a significant difference to the work lives of nurses. Very little. And in fact, the evidence that has been produced, this Wakil article is probably the most recent one, that tries to evaluate, whether digital solutions have really helped to give, quote, nurses more time to care, which is often the line that's used in these projects, has shown that yes, it released more time to care, but that time did not go back into care. It went either in two places. One was to non-direct care duties, which we all recognize, or it meant reducing staffing numbers because we're more efficient. So if we are going to make those kind of changes, then what are the arguments that we are going to make for a person-centered solution? I'm not against digital health or AI solutions. I was doing this a full presentation about this in Slovenia 2 weeks ago, and I was accused of being a kind of an AI dinosaur. And I thought, yes, I am. I'm not actually. And I'm not someone who's standing in the corner waiting for the iceberg to melt and us all to drown. That's not what I'm about. But I do think we have to ask some serious questions about our models of care, about how these solutions are actually helping to enhance our models or not. My take on this, in the conversations I have with directors of nursing also, is that digital and particularly electronic medical records have resulted in a proliferation of task-orientated practice rather than models of care. And yet we spend hours on end talking about models of care, but what I see and what our students experience is that they are given lists of tasks derived from the algorithms from the electronic record that they then go and do. Now, if that's our ambition, fantastic, just stick with it. But if our ambition is actually the personal narrative of the person who is receiving care, then that is not good enough. And in fact, that is a very dangerous road for us to go. And task orientation, we know, has a hugely detrimental impact on nursing practice. This slide just kind of summarizes some of that, and there's a long evidence base around the impact of task orientation on burnout and on staff satisfaction and on patient outcome. And we know that data. Some work that I did with a colleague in Norway, Astrid Skatvedt, where we were looking at community nurses' ability to support older people living at home in rural situations who had mental health problems. So they weren't on a diagnostic register as having a mental health problem. They were called kind of low-level mental health. And sometimes people might describe that, they're a bit sad or they're a bit lonely. They don't seem to be connecting. And yet these were people who community nurses were going into their houses day after day after day doing tasks. And yet they missed completely that most of these people had depression of some kind or other. They had chronic loneliness that was leading to aloneness and a sense of self-loss and self-worth, and that they had disconnected from society. Those nurses were doing a brilliant job in terms of doing those tasks that prescription provided for them to do, but were not seeing beyond it because they were on a time schedule, had so many people they needed to see every day, and were just focused on getting that task done. The outcome of that was that many of these people did have severe depression, and indeed one of the women in our study took her own life halfway through that study. So there is a serious side to the way we look at these so-called solutions in terms of what it means for human beings and what it means for how we connect on a relational capacity with each other as people. And algorithms are all very well, and we all are using AI daily without even thinking about it and sometimes not even knowing it. And so those algorithms are around us all the time. But we have to be careful about how much we pay attention to them and how much we see them as the answer to what we're doing. I had the honor recently of being awarded the Paul Tournier Prize for person-centered medicine. And Paul Tournier was a real hero of mine when I was doing my doctorate those years ago, because he was one of the first doctors to name emotional connection with patients was an important part of the role of doctors. So he was the first doctor to kind of state that publicly. And lived in Geneva, worked in Geneva. and had this amazing way of kind of predated Carl Rogers and all of that work around how we connect with people as persons. And what Tournier really kind of argued is that the role of the doctor is not just to see the person in front of them, but to really see the person in front of them. And that is to kind of go deeper than what is being presented to them. And that is because, as persons, we don't reveal everything about ourselves the first time we meet someone. It takes years and years and years to build up that relationship to really get to know that person. Now, of course, those of you who work in emergency departments could say, well, we see someone for 5 minutes, how the hell do we do person-centered care? And of course, you'd be right to ask that question, because it's about context. You know, you don't need to know every single thing about a person's life if they've come in with a broken finger. You do need to know enough about that person to know what it is that's going to matter to them in fixing that finger and what's going to go forward. But we don't reveal ourselves all the time, and hence why algorithms can never, ever be a solution to assessment, because they don't give you the whole picture, and not everyone tells everyone everything they need to know about them all the time. We pick and choose what the parts are that we tell. And of course, that is the key blind spot of AI. Sometimes when I'm feeling slightly despairing about some of this, then I think, no, AI can only be as good as those humans who are putting the stuff into that machine. Because the blind spot of AI, we know that there's a whole mountain of work happening to try and humanize robots, to try and get it as close as possible to the way that human beings think and feel. But we're not there yet. And while we're not there, I'm feeling slightly more confident about the whole thing. But the blind spot of AI is human agency, is our ability to determine our own destiny, our ability to look at who we are as persons and make decisions from that basis. And Martin Buber's work in that regard as a philosopher is really powerful in the sense of, I either treat you as another person, or I treat you as a thing. It's the difference, as he says, between an I-thou and an I-it relationship. And for me, a lot of the AI solutions are I-it relationships, treating people as things that we do things to and for, rather than a connected relationship where we're connecting on a relational, emotional capacity. And fundamentally, I think the danger is we rip the heart out of care. And even the Tin Man knew you needed a heart. That if he was going to get anywhere, then we had to hold on. He had to find his heart. And as you know, if you follow that story, then that's what he went in search of. He went in search of a heart. And my contention in summarizing all of this is that I feel really nervous about the fact that we are ripping the heart out of nursing. And that if we continue without having these more philosophical, conceptual conversations, then that is what we do. And that's okay if that's what we want, but I'm not convinced that is what we want or where we need to be going. And the reason is because person-centeredness, no matter what the language is we want to wrap around it, is built on the idea of personhood. Who am I as a person? What makes me a different person from you and you and you and you and you? Because none of us are the same. No matter how we try and standardize us, we are not the same, and we never will be. And what makes us different is our personhood. Those innate qualities of me as a person, my beliefs, my values, my motivations, my desires, my dreams, my hopes, my fears. They are what make me the person that I am, and what drive me to be the person that I am. There might be similar things to you, but they're not the same as you, because they manifest differently through the way you see the world, through the way you connect with the world, through the way you position yourself. And so we can only go so far in standardizing the person. And hence where we see this interesting dynamic, I think, between evidence-based practice and person-centered care. And how do we balance that dynamic is a key focus for us, and something we have to really pay careful attention to. The same with the whole things around patient-reported outcome measures to try and standardize particular outcomes. Again, we're doing some work moving from patient-reported outcomes to person-reported outcomes. How do we shift the lens from that kind of standardized person to a standardized person plus, where we are actually taking account of the individual narrative? But the core thing about personhood and who we are as persons is that we are never static. We are constantly changing. We are constantly in a state of transformation. And so we can't be held just by one particular process or one particular algorithm that tries to define me. And as Craig said, I'm currently one of the commissioners on the Lancet Commission for People-Centred Care for Universal Health Coverage, which is an amazing experience and honour to be one of those 20-something commissioners, the only nurse, which is a really good accolade to be in there. And I'm leading one of the programs of work, which is around redefining people-centeredness and coming up with some operational principles that can try and move forward from where the WHO work has been for over 15 years now. And recently, I was facilitating an online workshop with commissioners from 20 countries, where we started from the point of telling our own care stories. So this was a creative workshop at midnight because of time zones in Australia, of course. It's never going to be in the middle of the day, where we were using creativity and creative methods to tell our own stories about care, because we all have our own individual story of care. And it's easy to other people's work, but what about our own lived experience of care? So we started from that point of telling stories. And what was really fascinating about these 20 stories, which have formed the platform for now the scoping review that we're currently in the middle of, is the core thing that came out of this was the significance of human connection. That human connection in all of these stories was the make or break point in relation to care and care experience. Everything else, there were diverse stories, but it was that point of connection that really made the difference to whether it was a good care experience or a poor care experience. And we saw, as you can see on this slide, all kinds of contradictions and differences across these countries, around dignity, around racism, around connection and disconnection, around fragmented systems, around, the way people are dismissed within the system and how that actually operates. And the other really important lesson about all of this is that not one of those stories was dependent on the economy. So one of the worst stories of care was from here in Australia, of a child actually receiving the wrong surgery, the way the parents were handled, the way the parents were dismissed, the way they were lied to. And one of the parents is a commissioner, so he was relaying his story, which was terrible. Versus, one of the doctors in this group who works with homeless people in India, which you can imagine she works out of New Delhi, and an incredibly amazing story of human connection and human care that we would all want to receive wherever we are. So you have this huge difference. So people blame money as a reason why we can't give good care, and it's just not true. Because it is more about connection and the attitudes and how we bring ourselves into that space and how we connect with the other person. And I'm really intolerant now, I have to say, of nurses whose starting point is, I'm too busy, we don't have enough staff, we can't do it. I think it's bullshit, frankly. And I think we have to step away from it. It's not that it's not an issue, but it's not the issue. And we have to really start to look differently at what it is we're doing. So I think we have to rethink care, particularly with all of these changes that are happening and how it is that we're conceiving our models and what those models are going to look like in this kind of technologically driven world where the human connection is at risk in relation to how we connect with people. And so person-centered practice is, for me, the heart of this. It is where the heart sits and how we make that happen. Person-centered practice is a phrase we use in our work as opposed to person-centered care, and I'm happy to talk about that in discussion if you're interested in it, because for us, person-centered practice embraces the cultural component of practice. So person-centered care is what we do to, for, and with people who are using our services, but person-centered practice includes us as care providers too. It includes the managers, the CEOs, the structures, the systems. So it is a more holistic view of what we mean by person-centeredness. And as I said, and I really want to keep reiterating, there is no hierarchy of person in personhood. We are all equal persons. So when we talk about privileging patient care, we can only do that if we equally privilege the ability of staff and the context in which staff are working to provide that care. There's not an either or, it has to be the same. So this is our definition of person-centered practice, which has been around for a lot longer than 2021. That's the most recent iteration of it, and the one that's really guided the work that we do. That definition has very much shaped the person-centered practice framework, which, as I said, I've been dining out on for nearly 30 years now, and has really kind of shaped a lot of work around the world. And sometimes I'm blown away to the extent of how much this framework gets used and how people use it as a heuristic to really think through what they need to be paying attention to. We have developed, it's obviously got a strong theoretical basis and a lot of philosophical basis and concepts, but we also have developed a lot of frameworks and tools that people can use both for implementation but also for evaluation of their journeys as they go through person-centered culture change, which is a long process. And so a few things to end up with about the environment. So in the environment, leadership is key. As I've said, the nurse unit manager is often the one who's holding the responsibility for that environment. In some work we did, which was funded by the Royal College of Nursing in the UK, where we were asked to kind of work with the whole of the nursing and midwifery profession across the whole of the UK to look at what were the key attributes of nurse leaders that could help them to create these kind of cultures. And we did a realist evaluation and realist synthesis. And the three things that came out most strongly that nurse leaders have to have if they are going to create these kind of cultures is firstly knowing themselves as persons. What are their values? What are they driven by? Who are they? What's their makeup? So knowing their personhood, which is fantastic, that comes out so strongly. Secondly is embodying their values. That is not just about stating their values, but actually really living them and showing them. And that's come out in other work that we've done around implementation science previously. And then lastly, again, no surprise, is their visibility and availability. Managers who are visible and available to their teams have a much greater success factor than those who are not. And yet, a lot of our nursing developments remove managers from being visible and available directly to their teams. So again, something we have to pay attention to in the environment. We have developed this framework to try and work with how do we do this as a whole system. And I don't have any time to talk about it. I just wanted to raise it because a lot of this is captured through this 7S framework, but later we may have that discussion. But I've also identified on here some key things that I think we have to be paying attention to right now in each of these domains if we are going to start to make a difference, if we are going to shift this lens away from just talking about person-centered care as a word and as a philosophy to really embrace person-centered cultures, then we have to have these activities happening at these different levels. And again, we could do a whole day's workshop on picking each one of these activities that I feel very strongly are where we should be focusing our attention right now in relation to whole systems change and how we move forward. But also, I do want to just say something about our obsession with training. We are wasting so much money in just putting people on short-term training programs somehow to achieve more person-centered care. And again, there is no evidence to show that a half day's training is going to shift that lens, none. But yet we keep on doing it. We keep on putting that budget into this work. This is some research we did with Betty Ann Robinson, a colleague in Canada, in Halifax, where we spent 3 years as a 3-year action research study working with nurse educators across the whole of this health system to bring about a person-centered culture within women's health, so it was in a women's health hospital. And this is the journey of that. And what we showed was that creating this kind of shift is this intricate intrapersonal, interpersonal, and contextual journey. It's not a half-day training. It requires this consistent relationship building, this consistent kind of hand-holding, supporting, facilitation over this period of time. And yet, most of our nurse educators spend most of their time rolling out in-service, rolling out half-day training sessions, when actually we could really elevate this workforce and motivate this workforce to be doing this kind of work to a much deeper, consistent level. So, currently, I'm trying to kind of change the policy context. As Craig said, I'm working with the Sydney Policy Lab, the CARE programme. CARE stands for Championing Australians' Relational Economy, not care as in care, because what we're looking at is how do we get relationality as a core concept of the way we change policy. And I've got a whole array of projects that I'm currently leading in that space, from cardiac monitoring in remote settings and how do we build relationships for that, through to building, co-designing a mental health service in Western Sydney for refugee and immigrant women. And how do we kind of keep this idea of personhood as the core characteristic of how we build policy to support people's health as they go through these systems. So to conclude, I think it is great that we have this conversation space, that we have this local solution being held by JBI as a global organization, because we really do need to kind of grab the opportunities that are afforded to us right now in terms of shifting the lens on this work, and it feels like that is happening for me after all of these years. But what we have to do is just stop thinking that somehow we can simplify this whole thing to being about algorithms where we can tick off that we have attended to the person and the choices that they have made. It's just not enough, and I want us to think more deeply and more carefully and thoughtfully about how we do that. But what we do also have to remember, as I said, I started on this road in the 80s, is that it's very fragile. Person-centeredness is very fragile, and we can never stop placing the lens on the importance of needing to continuously manage the environment, build the relationships, and keep the person at the center of every decision we make, whatever that might be. Thank you.